What I thought I'd do is give everybody just a sneak preview of a lecture that I'm doing at the Northern Dental Summit in November, which is on avoiding occlusal pitfalls in aesthetic and restorative dentistry. And if you are at the show, we will be on stand D31 with the educational stand. And also my lecture will be on the 23rd of November, running from 12 o'clock through to 12:45. And that will be very much a practical case-based lecture on avoiding occlusal pitfalls in aesthetic and restorative dentistry. My background with restorative and aesthetic dentistry really comes from my consultant training and also my specialist training as well. In addition to that, I've also trained extensively throughout Europe and also within the States, and have really brought all these kind of occlusal philosophies together into what essentially is quite a straightforward and easy to digest theory of kind of practical occlusion. You find a lot of occlusion is bogged down in terminology and it's very much overcomplicated. And at the end of the day, occlusion is not complicated. So hopefully I'll try and get that across in the lecture, as I do in all my courses. With the courses that I run, it's very much practical based occlusion, working with the articulators, working with deprogrammers, working with occlusal analysis, making splints, so that we look at training people to have practical occlusal skills. That's what really my courses are all about. So really, what occlusal or TMD disorders may prejudice restorative or aesthetic dentistry? Well, there's quite a long list, and I'll really maybe just look at one or two of those now, and then in the lecture we'll consider more of these in detail. And certainly on the courses we spend a lot longer looking at all of these potential disorders. So we've got a lack of canine guidance, deep overbites, class 3 occlusions, the restricted envelope of function, which is very much an anterior interference, and separate to that we've got the posterior interference. In addition to that, there are night parafunction patients and also the day stress clenchers. But what we don't really know is we haven't got really good data on how many of our patients do night parafunction or do day stress clench. And I think a lot of the studies are vastly underestimating the numbers of patients that do this. In addition to this, there can be other biological factors, so not tooth position problems, not grinding or clenching problems, but also erosive diets and erosive conditions as well. And these kind of disorders, they can lead to tooth wear, they can lead to bone loss, they can lead to mobility, they can lead to all sorts of possible problems. Sometimes patients can cope well with these disorders, but a lot of the time they are causing problems. Particularly the tooth position problems, this is an issue as well, because if you put restorative dentistry into a restricted envelope, for instance, this can be very damaging and the restorations will fail very, very quickly. Likewise, if you put restorations into a night parafunction patient, even if they promise to wear the splint, etc., the splints don't cure the night parafunction, so they can end up, destroying the restorative dentistry that you've done. And you end up with dissatisfied patients, and the worst result is you end up with kind of medico-legal or issues with the General Dental Council. So just a little taste of the first thing that I would look at is the restricted envelope of function. And something very well described, and particularly from Northern America, but often quite neglected within Europe. And the restricted envelope of function I'll cover in more detail in the lecture. And it's very rare that I work in small groups on my courses, about 15. It's very rare we don't find somebody with a restricted envelope of function. And literally 2 days ago, I was running a course, and within that group of 15, 2 restricted envelopes of function, both quite mild ones, not as severe as this, but 2 were there and on dentists as well. So what is the envelope of function? It's really having the room to chew. So what you need is sufficient overjet of the teeth, and you don't want too much overbite of the occlusion either, because you need that little bit of room for the mandible to swing laterally and forward during that closing movement. And if you look at the slides here, you can see a very characteristic wear pattern. Palatal on the upper incisors, just to the intercuspal position, and then a little bit of incisal edge wear as well. With the lowers, you can see the wear is on the incisal edges and the upper buccal aspect of the lower teeth. But you could imagine as this wear progresses that this can cause all sorts of problems. They then turn up with cosmetic problems because the teeth are wearing. However, if you put composite or veneers in this situation, it will fail very, very prematurely. So certainly during the lecture, we'll look at this problem, but we'll also look at the solutions for this problem as well. So I won't cover that now, we'll cover that in the lecture. What else will we look at in the lecture? Well, we'll look at a practical and evidence-based approach to some of the splints, etc., that are out there. The problem with splints these days is a lot of splints are products. People are trying to sell you a product. So what I've done during my training and during my practical career is evaluate all of the different splints that are out there. And it isn't a case of one splint will cure everybody. You have to be able to have a flexible approach to this and consider the different types of splints out there. So for instance, here, this is a long-term anterior bite plane. And, with certain patients, this can be very, very effective, particularly with the clenchers, with helping to relieve symptoms of headache, etc. So we'll look at the evidence for these type of splints. But for instance, they're very, very popular at the moment, these partial coverage splints. But patients, if they wear them for too long, or they're a particular type of patient, they get over eruption of teeth and they're actually left in a worse situation. So we'll consider those in more detail during the lecture. In addition to that, what I'll also look at is not just splints and restorative, but let's look at some of the newer treatments as well. And certainly one of the newer treatments that we've got considerable experience with in my practice is the use of botulinum toxin, particularly for those patients who have, their severe masseteric clenchers. We do find that the Botox in the masseter can be really effective at improving their quality of life, reducing their symptoms, but also, I've used this on patients who have restorative work, who've repeatedly fractured restorative work, and it has a protective role as well. So we'll look at some of these new treatments as well. We'll also look at treatments such as Cerazen and treatments such as that as well. So that's just a little taster of what we'll be doing in the lecture. And the lecture itself really is more of a little taster of what we do in our wider courses. But what we will do in the lecture is we'll be concentrating on 2 or 3 of these more common disorders, but looking at how we can implement systems into our practice that will help with these problems. So if you can come and visit us at the stand D31 or come to the lecture and chat to me afterwards on the 23rd of November, that's absolutely fine. If you haven't got the opportunity for that, please come and visit our website, which is dhti.co.uk, because that has a range of videos on different subjects. Hopefully those videos will be of some real clinical benefit for you. So thank you for your time.